The radius is the lateral and shorter of the two forearm bones. Its proximal end includes a head, neck, and tuberosity. The head articulates with the capitulum superiorly at the elbow joint and with the radial notch of the ulna on the side at the superior radio-ulnar joint. The head is connected by a shaft with a broad distal end which articulates with the scaphoid and lunate bones at the wrist joint and with the ulna at the distal radio-ulnar joint. The head is palpable in the depression behind the lateral side of an extended elbow, where it can be felt rotating in pronation and supination. Place your index finger on the lateral epicondyle of the opposite humerus and your middle finger alongside it. The middle finger now lies on the radial head and it can be felt rotating when the forearm is pronated and supinated. The head is discoid. Superiorly, it articulates with the capitulum of the humerus during flexion and extension of the elbow joint. Since the elbow joint cannot be extended beyond 180 degrees, the capitulum does not extend on the back of the humerus. During full flexion, the head of the radius engages with the radial fossa on the front of the humerus. The circumference of the head articulates with a radial notch on the ulna at the superior radio-ulnar joint. The remaining part of the head articulates with the annular ligament. Below that, the loose fibers of the quadrate ligament are attached on the medial side of the neck. The quadrate ligament further protects the superior radio-ulnar joint. The annular ligament is U-shaped and it holds the radius in position at the superior radio-ulnar joint. Note how the annular ligament surrounds the head of the radius and how it is attached to the margins of the radial notch of the ulna. Also note that the capsule of the elbow joint continues with the superior radio-ulnar joint. A sudden pull of the arm of a child may partially dislocate the radial head through the ligament. This is called pulled elbow or nursemaid's elbow. The neck of the radius is a constriction distal to the head. The medial side of the shaft is characterized at its upper end by an oval prominence called the radial tuberosity. The radial tuberosity projects toward the ulna. The biceps tendon is attached along the posterior lip of the radial tuberosity and a bursa lies against the anterior surface. Because the tendon of biceps is attached at the posterior lip of the tuberosity of the radius, then when the biceps contracts, its tendon rotates the radius and supinates the forearm. Biceps is a powerful supinator of the forearm for this reason. Note the direction of the nutrient foramen in both the radius and ulna. It is directed to the elbow. To the elbow I go, from the knee I flee. Summarizes the direction of nutrient foramina in the long bones of the upper and lower limbs. The nutrient foramen of the humerus is another example. The nutrient artery is directed away from the growing end. The growing end of limb bones is the end at which most of the growth takes place. So the nutrient artery is directed away from the growing end, which is therefore the distal or lower end of the radius and ulna, while it's the proximal end of the humerus. From the anterior margin of the tuberosity, the anterior oblique line forms a ridge that runs down to the point of greatest convexity of the shaft. This anterior oblique line is mirrored by a similar but less prominent posterior oblique line on the extensor or posterior surface of the shaft. Between the two oblique lines, the shaft receives the insertion of supinator. This muscle forms part of the floor of the cubital fossa. It arises by two heads, humeral and ulnar heads. The humeral head from the lateral epicondyle of the humerus, posterior aspect of the lateral epicondyle, and the ulnar head, which lies deep, arises from the supinator crest and the supinator fossa of the ulna. Supinator
wraps around the back of the radius to be inserted into the proximal third of the shaft of the radius. Thus, when it contracts, it rotates the radius in supination.
At the apex of the two oblique lines, pronator teres is attached to the radius at the middle of its lateral border. If the radius is fractured proximal to the attachment of pronator teres, then the proximal fragment is supinated by the action of biceps, and the distal fragment is pronated by pronator teres. The fracture must therefore be splinted with the forearm supinated so that the distal fragment is aligned with the supinated proximal end. If the fracture is distal to the midshaft, the actions of biceps and pronator muscles more or less balance. Below the radial tuberosity, there is a sharp ridge for the interosseous membrane of the forearm. The fibers of the interosseous membrane pass down to the ulna. Thus, they are positioned to transmit forces received by the radius via the hand to the ulna for transmission to the humerus. The oblique cord is attached at the upper end and passes up to the ulna. At the flexor surface, flexor digitorum superficialis is attached along the anterior oblique line. Flexor pollicis longus arises from below this. At the lower part of the flexor surface, pronator quadratus is attached. On the extensor surface, below the posterior oblique line, is the oblique origin of abductor pollicis longus, and distal to this is the origin of extensor pollicis brevis. The shaft of the radius, in contrast to that of the ulna, gradually enlarges as it passes distally, so that the lower part of the bone is rectangular, that's to say four-sided in transverse section and when looked at end-on. The ulnar surface shows a notch for articulation with the head of the ulna. The triangular area above this receives pronator quadratus, and the interosseous membrane is attached along the posterior edge. The anterior surface has pronator quadratus attached on it. Laterally, the lower end is projected into the pyramidal styloid process. To the tip of the styloid process, the lateral collateral ligament of the wrist joint is attached. Into the base of the styloid process, the tendon of brachioradialis is inserted. The radial styloid process is larger than the ulnar styloid process and extends farther distally. This relationship is of clinical importance when the ulna and or the radius is fractured. In this X-ray of the wrist, note the normal relation of the styloid process of the radius, which is distal to that of the ulna. In fracture of the distal end of the radius, this relationship is disturbed, and as you can see here, both styloid processes can be seen to lie on the same line. The radial styloid process can be easily palpated in the anatomical snuff box on the lateral side of the wrist, especially when the thumb is abducted. As has been mentioned, it is larger and about 1 centimeter more distal to that of the ulnar styloid process. Because of this fact, more ulnar deviation than radial deviation of the wrist is possible. On yourself, try ulnar deviation, that's to say adduction, at the wrist and compare it with the range of radial deviation or abduction of the wrist. Ulnar deviation has more range than radial deviation. The extensor retinaculum is attached to the anterolateral border above the styloid process. This fascial band runs obliquely to its distal attachment on the ulnar side of the carpus. It's a thickening of the deep fascia that binds down the long extensor tendons of the forearm. Septa pass from its deep surface to the radius, making the compartments for the extensor tendons. 4 of these compartments lie on the radius. A 5th compartment lies over the radio-ulnar joint, distal radio-ulnar joint, and the 6th compartment lies over the head of the ulna. The tendons of abductor pollicis longus and extensor pollicis brevis lie in a single compartment on the lateral surface. The posterior surface is characterized by the presence of a prominent dorsal tubercle of Lister. This tubercle can be palpated around the middle of the dorsal aspect. The tubercle of Lister, or the radial tubercle, is small, hence the name tubercle, in contrast to the bigger tuberosity at the proximal end of the bone. The names should not be confused. A broad groove lies lateral to the dorsal tubercle. This broad groove lateral to the dorsal tubercle lodges the flat tendons of extensor carpi radialis longus and brevis. On the ulnar side of the dorsal tubercle is a narrow groove for the tendon of extensor pollicis longus. The dorsal tubercle thus acts as a pulley for this tendon of extensor pollicis longus, as it changes its direction. Between this and the ulnar notch is another broad groove for the four tendons of extensor digitorum together with the tendon of extensor indicis deep to them. The tendon of extensor digiti minimi crosses the radio-ulnar joint in a separate compartment. Inferiorly, the articular surface of the wrist joint has two areas. The medial surface is square and articulates with the lunate. To the border between this surface and the ulnar notch is attached a triangular fibrocartilage. The apex of the fibrocartilage is attached to the styloid process of the ulna. This fibrocartilage thus separates the distal radio-ulnar joint from the wrist joint. The lateral area on the distal end is triangular and it articulates with the scaphoid bone. During pronation and supination, the head of the radius rotates on the capitulum. The lower end of the radius, carrying the hand with it, swings around the lower end of the ulna. The ulna is fixed. The expanded lower end takes the full thrust of a fall on the outstretched hand and may lead to Colles fracture of the lower end. The interosseous membrane transmits forces from the wrist to the elbow via the lower end of the radius, which participates in the wrist joint, to the upper end of the ulna. Since proximally the ulna has a firm articulation with the humerus, then the forces are transmitted to the humerus.